Hello guys. So yet again, I'm back with a new snapshot. So welcome to Gynae Wizard Snapshot series. So in my snapshot number 4, we'll start with a brief case scenario. So in my gynec OPD, I saw a 53-year-old woman who's attained menopause 7 years back, and she comes with a complaints of dryness of the vagina, and she also complains some amount of itching and dyspareunia as well. So, in detailed history taking, she tells that she doesn't have any white discharge per vagina or she doesn't have any bleeding, that is postmenopausal bleeding. She's a para 3 living 3 and she's attained menopause 7 years back and previous menstrual cycles were regular. And she does not have any other comorbidities and a detailed physical examination was done and her systemic examination was within normal limits. Then I proceeded to do a gynecological examination. Her per abdomen was soft and external genitalia was normal and appropriate for the age. Then I proceeded by doing a perspectivum examination and I also asked her about the history of pap smear and she had not taken the screening and it was done 5 years back. So then I visualized some amount of vaginal epithelium thinning and there were certain spots on the vagina, so it looked more like an atrophic vaginitis. Her cervix was normal, and a pap smear was taken, and a bimanual examination was done, and uterus was retroverted, atrophic, and bilateral fornices were free and non-tender. So then I came with a provisional diagnosis of atrophic vaginitis, including genitourinary syndrome, because she also had history of repeated urinary tract infections and increased frequency, and she had consulted some local doctors, and it was not that beneficial. So let us understand what is the main cause of this and why does she have all these clinical manifestations and what is the main mechanism to treat this and what is the management aspect. So by now you would understand my snapshot for today is about menopause and menopausal hormonal therapy. So we have to understand what do we mean by menopause. So what are the clinical manifestations of menopause and what is the management aspect as well. So in management, we have to in detail understand the importance of menopause hormonal treatment. And now we have certain non-pharmacological therapy also, which is equally important and we have to know certain points about it as well. So, why delay? Let's move on to the topic proper. So, what do you mean by menopause? So, menopause, as the name itself suggests, that it is a permanent cessation of menstruation. Permanent cessation of menses, and what we call it as a final menstrual period. So when we have this permanent sensation of menses, so it is always a retrospective diagnosis. So why do we tell it is a retrospective diagnosis? Because this is followed by 12 months of amenorrhea. So whenever there is 12 months of amenorrhea, we tell that she is attained menopause. So some of the years preceding menopause and a year after menopause is regarded as the perimenopausal age group in which all these clinical manifestations take place. So, in this, it is to precisely tell that the perimenopausal age group is between 3 to 5 years preceding menopause and 1 year after menopause is the main period called as a perimenopausal age group. And once after menopause is achieved, it is called as the postmenopausal age group. So, whatever clinical manifestations are there will take place in these respective periods. So, this is called as the stages of menopause, which is from the perimenopausal period. So, it's the transition between reproductive age to the menopausal age. And in this transition, there are few changes which occur both physically and emotionally, and this will be regarded as the clinical manifestations which the woman present to you with. So this is in brief about what is the definition and what are the stages of menopause. So in India, the range or the time in which the woman usually attain menopause is around 45 to 50 years, with 46 years being the most common time of where the woman attain menopause. Whereas in the US and UK, the menopause is usually around 51 years. So in India, it is around 46 years, and in the UK and US, it is around 51 years. So in these years where they have a transition between this, what is happening? There is mainly the decline of the ovarian function. So there is absolute decline and there is loss of ovarian function. Once the follicles get depleted, that is when she achieves her final menstrual period. So whenever the follicles are depleted and the ovarian reserve is empty, what happens? Because there is no negative feedback inhibition from the estrogen, what will happen? There is increased secretion of the gonadotropins. So if we have to biochemically know whether she is attained menopause or not, according to the Indian Menopause Society, they define menopause that if the FSH is more than 40 international units, at least repeated 4 to 6 weeks apart, and if it is still more than 40, we regard it as menopause. And this menopause has different types. So what is it? It's a natural menopause, which I told you that the woman attains once the ovarian function is depleted. The second thing is an artificial menopause, which might be due to any surgical reason. Like if there was a bilateral oophorectomy, then she's attained a surgical menopause. And certain times, if she is on any cancer treatment, if she is subjected to radiotherapy or chemotherapy, even these are they are toxic to the ovaries. So that time also she might attain something called as a medical menopause. So all these are something which is induced, and there is something called as natural. So natural menopause is natural depletion of the ovarian reserve, where artificial menopause is because either surgically or medically we have induced menopause. So in these women who have surgically induced menopause, they have a higher range of clinical manifestations when compared to women who have gradually underwent to this transition. So this is a very important take home point. And certain times there is something called as a premature menopause, and we absolutely define it as less than 40 years of age if there is complete ovarian depletion. So we use the term called as premature ovarian insufficiency. And the definition of premature ovarian insufficiency is when the woman attains menopause in less than two standard deviations of particular age and of the particular age in a particular geographical area, then we regard it as premature ovarian insufficiency. For example, in India, the natural age of menopause is around 46 years. So if by 38 years, if she undergoes menopause or if she attains menopause, we call it as premature ovarian insufficiency. So they might come with complaints of amenorrhea, that is mainly the secondary amenorrhea, and certain times they might be anxious to conceive and they come with secondary infertility. And then if you evaluate them for further, you might make a diagnosis of premature ovarian insufficiency, where the FSH values will be more than 25 international units, at least repeated 4 weeks apart. So then you will diagnose them with premature ovarian insufficiency, and the only management for infertility in such women will be oocyte donation, because the ovarian follicles have completely depleted. So this is where we understand what are the different types of menopause. So whatever the case might be, it is mainly because of the absolute estrogen deficiency, the range of clinical manifestations will occur. So we might think that estrogen receptors are only present in the reproductive organs. No, the receptors are present in so many different organs in our body. So there are two types of estrogen receptors. There is estrogen receptor alpha and estrogen receptor beta. So these are the cytoplasmic receptors which are present, and these are the steroid receptors because these are steroids, and these alpha receptors are mainly present in the reproductive organs like the uterus, in the endometrium, to be precise, the ovary, the fallopian tube, the vagina. So all these reproductive organs have the alpha receptors, whereas the beta receptors are present in different other parts like the brain, the bone, the cardiovascular system, the arteries. So all these are the non-reproductive organs which have the beta receptors. So whenever there is deficiency of the estrogen secretion, especially from the ovaries, once the attainment of menopause is there, so we have varied clinical manifestations. And under these clinical manifestations, the main important manifestations we have to remember are the vasomotor symptoms, genitourinary syndrome, neuropsychiatry syndrome, and because of the estrogen deficiency, the woman undergoes increased risk of fractures because of osteoporosis as well. So these are the important clinical manifestations which occur during the postmenopausal age group. And especially vasomotor symptoms is something which is called as the hot flashes or hot flushes, is mainly because of the deficiency of estrogen. There is absence of thermoregulation. So what she will experience, she will suddenly experience a flash of heat on the face and upper part of the chest, which becomes generalized. And because of this heat, what will happen? It is mainly because of the absence of thermoregulation. What will happen? The core body temperature will decrease. And once the core body temperature decreases, the response to this will be intense perspiration and sweating, and she will start shivering to maintain the to maintain the body temperature, that is the core body temperature. So this sequence of events which take place is called as the vasomotor symptoms. Again, there are different criterias for mild to moderate and severe, and usually this lasts for around 3 to 5 years post menopause, and in less than 10 to 20% of the women, they have vasomotor symptoms even after 20 years of age group. So in these women who have these vasomotor symptoms, it is very difficult for them to cope up. And the woman with higher BMI, or women who have a history of smoking, or women who have hyperthyroidism, so all these women have more chances of development of these vasomotor symptoms, and these are common in women who have attained a earlier menopause when compared to women who have attained a later menopause. So these are the very important clinical manifestations which require treatment, and we cannot just ignore those complaints. And the second important thing is the local estrogen effect on the vagina, which causes the vaginal dryness, vaginal itching, and sometimes there might be spotting or bleeding because of the atrophic vaginitis, and also she might complain of dysmenorrhea, and all these together will be called as the genitourinary syndrome. And even these estrogenic receptors are present in the urethra and bladder, and whenever there is thinning of the urethral epithelium, there is loss of coaptation, and they'll be more prone for urinary tract infection also. And the vaginal pH will drastically increase because of the absence of Dodderline bacilli, and hence they'll be more prone for vaginal infections, and this might exacerbate the situation. And that is about genitourinary syndrome. And lastly, we have to speak about neuropsychiatry syndrome. Because of these estrogen receptors in the brain, they help in cognition also. So whenever this cognition deficiency is there, she might have certain absence of so she might forget, she has increased forgetfulness, she has lethargy, she has mood disturbances, sometimes anxiety, sometimes depression. So all these cumulative symptoms will tell that she has certain neuropsychiatry syndrome as well. And because of the absolute estrogen deficiency, there is increased risk of osteoporosis especially in the postmenopausal age group, and she will be more prone for fractures also. So these are all cumulatively called as the clinical manifestations which occur in the postmenopausal age group. So now what we have to do? Definitely she requires management. So we cannot ignore her complaints, and we should never ignore the geriatric patients who come to your OPD with all these postmenopausal symptoms. We have to take a proper history. Physical examination should be done, including the gynecological examination, and some of the investigations have to be done to rule out other malignancies. So you have to screen for endometrial, ovarian, breast cancer, colon cancer if she has any hereditary risk or family risk, and we have to rule out all other things in her history, examination, and investigations, and then we have to properly manage her, because these women are often ignored in the house and outside the house as well. So it is as a response, it is our responsibility of being a gynecologist to pay heed to their problems and give some attention and manage them appropriately. So this was the main reason I wanted to make a snapshot on this. So let us now understand how do we go about the management point of view. So when it comes to management point of view, we can divide management as the general measures which we advise the woman in the menopausal age group, and we also have the pharmacological management, and we have certain evidence about the non-pharmacological management. So when it comes to general instructions, it is important for all the women in the postmenopausal age group to follow certain criteria. So what is it? It is firstly, they have to pay attention to their nutrition. So diet is very important, and especially intake of calcium and vitamin D is recommended. So the recommended daily allowance of calcium is minimum around 1000 to 1200 mg per day. So they can either take it through tablets or through the diet. So at least 500 mg of tablet they can take, and 500 mg through their diet by adequate sources like milk, ragi, etc. They can include it in their diet. And vitamin D3 is also equally important for their bone strength. 600 to 800 international units of vitamin D3 is recommended on a daily basis. So that is one about nutrition. The second one is exercise. So though they are in the postmenopausal age group, they have to exercise, and especially two things are important when it comes to exercise. So firstly, they have to do some cardio, that is, they have to have movement. So what does movement mean? So at least 150 minutes of exercise, either walking, brisk walking, or gym, strength training. So all these they have to inculcate into their day to day lifestyle, and these lifestyle modifications are very important. So at least 150 minutes of exercise in a week, and at least 2 days of strength training is required in a week. So this is recommended to all the postmenopausal women. So one is the diet, second one is exercise, the third one is some relaxation methods like yoga to improve their flexibility, meditation, and going to a vacation, spending time with family. So all these are also very important. And the fourth thing is to decrease stress. So whatever might be their profession or their non-professionals, but still they have to manage their stress. So stress management is equally important, because this might also aggravate their manifestations. And the last one is they have to have good amount of sleep. So at least 6 to 8 hours of sleep in the night. So sound sleep is also very important to avoid all these symptoms. So these are the five milestones, or these are the five important advice you will give as a part of general management: nutrition and diet, exercise, sleep, stress, and some relaxation methods. So all these five pillars of management of menopause is very important. Next, when coming to the non-pharmacological and pharmacological management. So non-pharmacological management, so they used to tell that these phytoestrogens like soy, isoflavones, all these can be used, black quashish, all this can be used in the management of clinical manifestations, especially vasomotor symptoms, but the reduction in these is just 40 to 50%, and these do not have a safety value. So we do not know whether they are safe in the future or they have any side effects. So the evidence tells that the safety is still uncertain, and it is not recommended according to the NICE guidelines or International Menopause Society guidelines, or it is not adapted in Indian menopause guidelines as well. So the main uh, thing which we have to remember is the role of menopausal hormonal therapy. So the snapshot of today is this slide, that is telling about the menopause hormonal therapy. So this is the snapshot for today, which depicts the flowchart for prescription of menopause hormonal therapy, which is taken by the Indian Menopause Society guidelines, which was amended in the year 2022. So these Indian menopause guidelines give a clear picture for us to when to start MHT, whom to start MHT, how to start the dose, and how to follow up. So all these points are important when it comes to menopause hormone therapy. So let us go through this algorithm, which is very beautiful to understand. So assess the patient criteria. So how do you assess the patient's criteria? You have to see whether she is eligible for MHT, what are the menopausal symptoms she has, what is regarding the bone health, and is she having any premature ovarian insufficiency or early menopause. All these we have to rule out. And the two important parameters when it comes to MHT is her age should be less than 60 years, because the benefit to risk ratio with less than 60 years is more when it comes to menopause hormonal therapy, or at least they should be less than 10 years from the onset of menopause. So these are the two important criteria. I will repeat once again. Age should be less than 60 years, and at least there should be only 10 years since she is underwent menopause. So it should be less than 10 years since she is attained menopause, because less than 60 and less than 10 years since menopause, these women have a higher benefit with menopausal hormonal therapy when compared to women with more than 60 years age group, or if they have already surpassed menopause 10 years ago, then it is not that beneficial, because in these women the risks overweigh the benefits. So these are the very important criteria for us to consider MHT. So if their age is more than 60, or if it is more than 10 years of menopause, you please consider non-hormonal options, because giving estrogen or giving MHT in these women will be very risky, because there is higher development of risk of stroke or CVD or any other mm, uh, risk factors, and there is increased risk of breast cancer. All these risks are overweighing the benefits, and that is why we have to consider non-hormonal options. So if these criteria are fulfilled, then we have to look for any contraindications. So what are the contraindications? So if she is a case of established cardiovascular disease, and if she has increased risk of cardiovascular disease, or if she has previous past history of any thromboembolism, so all these are contraindications. Even SLE, diabetes with end organ damage, if she has any active endometrial or gynecological cancers, breast cancer, or if she is a high risk of breast cancer, that is if she has any family history of breast cancer, even these are contraindications for MHT. And next, the severe active liver disease and abnormal liver function, and if she has any undiagnosed abnormal vaginal bleeding which is not evaluating, or if you are suspecting pregnancy, even these belong to the contraindication. So if all these are present, please do not consider the MHT. So only in women you with controlled non-obese type 2 diabetes, or if they have sexual dysfunction, only in them we can prefer estrogen. But if it is uncontrolled, if she has CVD risk, if she has breast cancer risk, if you are suspecting pregnancy, or if she has any other cancers, or if there is any abnormal vaginal bleeding, please don't give MHT. And then you have to exercise a caution also in some women with hypertriglyceridemia, active gallbladder disease, if they have moderate risk for CVD, if they have migraine, deep vein thrombosis, varicose vein, if all these are present also, you cannot give oral estrogen. So oral estrogen is contraindicated. In such women, we can consider giving transdermal estrogen, because transdermal estrogen is absorbed locally and systemic side effects have been reduced. And then you have to evaluate the cardiovascular risk, breast cancer risk, and if all these are absent, then only you have to consider MHT. So if they have cardiovascular disease and breast cancer risk, please consider other options. If there are no risks, then only we have to consider MHT. And when giving MHT, you have to see whether uterus is present or absent. So if uterus is absent because of hysterectomy or anything, you can give only estrogen. But if uterus is present, always consider estrogen plus progesterone. Why? Because if you give unopposed estrogen, might lead to endometrial hyperplasia or endometrial carcinoma. So it is not recommended to give estrogen alone in a patient who has her uterus. But if you are giving estrogen and she has a Mirena in situ, then only oral estrogen can be given. So in Mirena in situ patients and hysterectomized patients, oral estrogen is tolerated. But if uterus is present and there is no Mirena, it is always recommended to give estrogen along with progesterone, which is orally given. So this forms the something called as menopausal hormonal therapy. So menopause hormonal therapy can be divided into estrogen plus progesterone, estrogen only, tibolone, and other modalities of treatment, that those are pharmacological drugs like SERMs, SPRMs, and tibolone, which is a steer. So selective estrogen regulator. So that is also tibolone, which contains both estrogenic, androgenic, and progesterone effect, and it has a negative effect over the breast. So that is why it is mainly preferred in women who have a breast cancer risk, and people who have mood disturbances and vaginal genitourinary syndrome. These people can also be considered by giving tibolone. So tibolone is also one of the drug which can be considered to be given if you do not want to give estrogen and progesterone. And once estrogen and progesterone is considered, again there are two types of treatment. So one is called as a sequential treatment and the other one is called as a continuous treatment. So what do you mean by sequential? So you give estrogen continuously for the whole cycle and progesterone is added only for 12 to 14 days in the last. So that is called as combined sequential therapy. So people who are attained menopause at an earlier age group and who require estrogen slightly higher when compared to the progesterone, and people who have underwent a who have underwent POI or whatever. So for them, you can consider a sequential therapy. But in post-menopausal woman, it is always better to give continuous estrogen and progesterone. So continuous combined estrogen and progesterone is preferred in postmenopausal age group. But in premenopausal with vasomotor symptoms and all, you can give sequential, or early menopause if they have had. For them also, you can give sequential where the whole cycle estrogen is given and progesterone is added only at the end of the cycle, that is 12 to 14 days. So this is the two types of treatment when it comes to estrogen and progesterone. So this snapshot diagram of menopausal hormonal therapy is very important for you to remember. So now we have understood for whom we can give and what are the regimens available. And so these two tables are the drugs which are available. So whenever you are considering the estrogen, so there is conjugated equine estrogen, there is 17 beta estradiol which is orally available. Transdermal patch is there, transdermal gel is there, and also oral estradiol valerate is there. And we have all these dosages and how do we give the dosage. So if they have attained menopause early or they are in that premenopausal age group where these vasomotor symptoms are present, so you can start with some higher dose. But if they are completely postmenopausal, you start with a lower dose and titrate. So the principle which you have to remember is you have to give the smallest possible dose, plus shortest duration of time. So these are the two important things which you have to remember when it comes to menopause hormonal therapy. And progesterones can either be given in the form of dydrogesterone or progesterone gel or oral, or you can oral or vaginal, or you can, those are micronized progesterone or levonorgestrel. You can either give in the form of oral dose or you can put a Mirena in situ. So this is about the types and doses of progesterone and estrogen. Now what you have to remember is how you will start giving, how will you prescribe. So firstly, you have to take a detailed history, do a physical examination and investigations. You have to do CBC, serology, TSH, HbA1c, and you have to do a mammogram, you have to do a pap smear and do a transvaginal ultrasound to see the endometrial thickness. It should be less than 4 mm. So after ruling out the risk of endometrial cancer, ovarian cancer, breast cancer and all other comorbidities has to be managed and they have to be in a euglycemic state. If they are diabetic, you have to bring back the hypertension to normal. So there should be normotensive. So once the patient is stabilized in all manners, then you have to take a detailed consent, explain them the importance of MHT, the risks, the benefits, and why it is indicated. So you have to mention the indication. So only women with vasomotor symptoms, who have genitourinary syndrome and who have neuropsychiatric syndrome, only for them it is indicated. For whom it is contraindicated, we have already understood in the previous flowchart. And also, we can never give MHT as a role of prevention. So you cannot prevent Alzheimer's, or you cannot prevent osteoporosis, or you cannot prevent breast cancer or CVD risk, or you cannot prevent thromboembolism. So to prevent, you please don't give MHT. Only to treat the clinical manifestations of MHT, it is indicated. And when it comes to vaginal dryness or vaginal itching, or when it comes to genitourinary syndrome, instead of systemic MHT, you can consider a vaginal cream or a vaginal gel. So this is the MHT formulations which are available in India. So if they have vasomotor symptoms or neuropsychiatric symptoms, these are the estrogens and progesterones which are available, and these are the combination, that is continuous sequential and continuous combined drugs of estrogen and progesterone, which is important. And Tubolone 2.5 mg per day orally can be started, and after 3 months it can be shifted to 1.25 mg if the efficacy is the same. So the effect is same. And for genitourinary syndrome, it is always better to consider estriol cream. So we have different brands like Primarin, Evelon and all. So conjugated equine estrogen also can be given in the dosage of 0.625 mg. So mainly vaginal gel at least 2 times in a day they can apply, or they can take MHT. And one more important point is MHT is not contraception. So it does not give a contraceptive benefit in the premenopausal age group, because contraceptives have a higher dose of estrogen and progesterone. But MHT, it mimics the natural endogenous estrogen and progesterone to suffice for prevention of all these symptoms. Those are the premenopausal or climacteric symptoms which the patient presents to you with. So it cannot be a replacement for contraception. So the MHT is different, contraception is different. So these are the various formulations which are available in India, and we have to also discuss the cost of this with the woman. And how do we follow up the woman? So after starting MHT, 1 month later, you have to call her, ask her if she has any side effects, if she has any undiagnosed vaginal bleeding, if she has any other symptoms, whether her symptoms have reduced or not. So all these things you have to follow up immediately after 1 month. Then immediately after 3 months, again you have to call up for next follow-up visit. And after 6 months, you have to follow up once again, and then annually you have to follow her up. So usually when to continue these MHT, so if they are have attained a surgical menopause, or it's an induced menopause, or if she is a POI case, for them you can continue MHT till 51 years. That is the average age of menopause, that is the natural age of menopause. Or it is always better to continue estrogen and progesterone for about 3 to 5 years. If you are giving only estrogen alone, you have to give it for 7 years maximum. And how many years you have to follow up? So you have called her on 1 month, 3 months, 6 months, and up to annually up to 20 years, it is always better to follow up. So this is in detail about when to start, whom to start, what to start, and how to follow up a case of menopausal woman with medical menopausal hormonal therapy. So this is in detail about MHT. Lastly, I want to conclude by saying menopause is very important, and we have to never ignore the symptoms if the woman comes to you with all these postmenopausal symptoms. And it is always better to establish menopausal clinics in your respective healthcare and pay heed to their problems and give their necessary care. And October 18th is regarded as a World Menopausal Day, and the theme for 2025 is to emphasize on lifestyle modifications, which I mentioned in my previous slide. So let's not take them for granted. Let us give the proper care and management, and let us advise them what is the best, which is to be done in those years of menopause. So we have to pay attention to their problems. So with this, I conclude my snapshot. And for more information regarding gynecological and obstetric problems and solutions, subscribe to my channel, that is Gynae Wizard. And I also hold a postgraduate course. So if you're interested, you can email me on gynewizard@gmail.com. Thank you. Have a nice day. Happy learning.